6 minutes, 6 minutes. Okay, here we go. So I'm here representing the clinical and operational teams from Spectrum, teams of which I am very proud to be part. Go team, all here today. Okay, I'm going to focus on two things that we've done in the last year. Is that me making this? Can I get an extra 5 minutes, 5 seconds? Okay, so the first thing we'll focus on is we had the opportunity to open a new mobile program, and it's been very interesting experience. So the features of our program, that's the mobile van, that tricked out RV. Just to let you guys know, it took well over a year to get that tricked out like that. It was quite a lot of work. So this is not an overnight project. We have set it up to make 3 stops. A food program sponsored by a church, the homeless shelter, guys, and a Spectrum-owned lot and building. So we've expanded our daily medication site options in Worcester. Oh, I'm sorry. Now I can talk slower. Okay, so what we've accomplished is expanding dosing sites from 2 to 5 in the city of Worcester. And we even were able to use this to add an additional site, an emergency shelter in Worcester that was open for the winter. So a lot more flexibility. We've been able to complete a lot of admissions. We have set it up to do admissions as well as daily medicating. So an average of 150 people medicate daily on the mobile unit. We have 300 patients assigned to the mobile unit because everyone has to have a clinical home. But we actually have served over 800 people with this mobile unit in some way. And so my next slide is just to show you sort of lessons we've learned and challenges we've faced. It's been so helpful to have partnerships with other service providers. So this food program in particular serves a very high volume of patients, both housed and unhoused. And it's a church that owns its own land. So when we said we'd like to come there and do this service, it was completely consistent with their mission. We had no issues with siting. It was the most seamless, expansion of services we've ever done. No NIMBY stuff with that church, right? Interestingly, having a predictable schedule of sites has been very helpful. Homeless patients plan where they're going to be at what times. And so we've set it up as a schedule. We're here from 8 to 10. If you miss us at 10, come to that next spot at 10:01 and we'll take care of you there. And of course, as you guys, I'm sure all realize, having more sites means more access, right? It's that whole 15 minutes, 30 minutes, being able to get someplace when you still have, restrictions on your daily dosing and needing to have observed dosing makes a big difference. Okay, lessons we've learned. Siting. You can't just park that big RV anywhere. In fact, very specifically, we've been told no to the library, no to public parks, no in pharmacy parking lots, commercial and retail spaces, and of course, nowhere near residential areas, right? Which rules out most of the city. It has been we set this mobile unit up to be able to complete admissions on the van, but it's actually been really helpful. We do admissions now in the dining room of the church hall, because when someone is in the unit doing an admission and it takes maybe a half hour, 45 minutes, that actually restricts the flow of patients medicating, right? So we're able to now do admissions. We tried to do them at the shelter. We were very successful doing them at the church, and that's going to really be our model, is to have the mobile team there, but try to get additional space so that we don't hold up the medicating process by the admissions process. We've decided to focus the service just on methadone. Of course, you can provide any medications through these units, but we don't have that need in Worcester. There are multiple office-based buprenorphine providers. That is not the acute need. It's really getting increased access to methadone medication. And then the van. When I said maintenance here, that's not methadone maintenance. That's the van. So what do you do when that monstrosity breaks down and you have 300 people or 150 people a day who are dependent on it? You can't just call somebody at 6 o'clock in the morning, can you come change the drive shaft? and then we'll get the thing back on target. So that's been a real challenge. There's no like van backup. When you pay all that money and take all that time to trick this thing out, you don't have a spare in the garage waiting to go. The other thing I wanted to talk about is our support of skilled nursing facilities. So in general, the situation is that OTP patients who need skilled nursing facility level care have had real challenges. How many of you are aware of this problem? Yeah, everybody. So they're trying to come out of the hospital. They don't need acute hospital level of care anymore, but you go to refer them to a SNF and it's like, we can't take them there on methadone, right? That's not okay. So we've been real fortunate to have some support to develop this partnership. We've had 3 willing partners within Worcester, 1 partner in Pittsfield, and 1 willing partner who we had to fire in Haverhill. So, there are many challenges. These people are very complex. They are very sick, right? They might stay 1 to 2 weeks. They might move in there and never move out, right? It's very unpredictable. They're referred into the Worcester area because we have this relationship from all over the state, right? And so those of you from other OTPs, if you're not working with SNFs, let me ask you right now, why not? Right? So be happy to talk to you about how we've made that work and how we've been able to get around some of the challenges. The model is that we have a service agreement. We deliver the medications to the unit, and they are administered by the staff at the SNF, right? We're not going in there and doing daily observed dosing. The patients are not self-managing their own medication. That has pros and cons, right? That means my staff is deployed not just once a week, but also when there are new admissions, we still have to deploy nursing staff to the SNF to take the medication doses. How am I doing? All right, I'm going to get the hook here. 1 minute. Okay. On the other hand, it depends on the staff at the SNF to manage the medication safely. And this is why the relationship in Haverhill did not work. Multiple episodes of the wrong patient getting the wrong medication at the wrong time, multiple episodes. And we just did not feel it was safe, that honestly, they couldn't handle it. I hate to say that, but we pulled back for safety reasons. Okay, lots of challenges with this that I'd be happy to talk to anybody about. One of the things, again, since I'm being annoying and challenging to my OTP colleagues, right now we bring people in as guests from other programs because we don't want to interrupt the continuity of the relationship with their home program. And it's really resource intensive to admit people who don't even come on site, right? So SAMHSA sort of teased us with the idea that we could do remote telehealth admissions for OTP and then pulled back at the last minute. We were ready to do that for all of these SNF patients so they wouldn't have to leave and come over. But anyway, what I would say is we're trying to maintain that relationship. Right now, when they get to about 30 days in the SNFs, we are admitting them. But some of our partners, as soon as a patient goes into the acute care hospital, it's gone for 5 days, they discharge the patient. And when we call to say we'd like to coordinate care with you, they tell us that they're not their patient anymore. So could you stop doing that? And we'll be happy to take care of your patients while they're with us. Robert, I'll let you do this slide.
I'm going to just check that this is not squealing. I think we had 2 mics on at the same time, so let's try to use this one.
All right, hey everyone. I'm Anthony English, physician assistant at BHN, and I work in a variety of capacities, including a few of the OTP clinics. And so today I'm going to go over BHN's methadone missed dose policies. So first, I'm going to pose a question for somebody to answer. You can raise your hand. What is the reason why we decrease somebody's methadone dose after they miss so many days of dosing? Serial number, yeah. So basically, we are concerned for decreased tolerance at the opioid receptors with concern for sedation or overdose if we continue their original dose. Exactly. So follow-up question, if somebody is using a subjective therapeutic amount of fentanyl daily, in the interim, when they miss their methadone doses, do we suspect that their tolerance at the opioid receptor is decreased, the same, or increased? Yeah, so studies presented to me through a lecture showed that tolerance at the opioid receptors for the most part, remain the same when folks miss their methadone doses and they're using a therapeutic amount of fentanyl daily. So that prompted Dr. Ruth Poteet, Dr. Ari Kriegson, and myself to revamp the methadone missed dose policies to now include two different pathways, one for without daily fentanyl use and one for with daily fentanyl use. So jumping into the first pathway without daily fentanyl use, this was actually the only pathway that existed at BHN for the past 4 years before we created the second pathway. And I mentioned that because it served us well for the past 4 years, and we have a census of about 1,500 to 2,000 patients that we serve annually. And we had no bad outcomes in terms of giving patients too much methadone with this dosing policy. There's a lot of other clinics that exist across the country that have much more punishing missed dose policies and resulting in subtherapeutic dosing for patients. And so we have not had any bad outcomes in terms of overdosing patients, but we realized that we were underdosing some of the folks who were continuing to use in the interim. And so to go over the policy, the without daily fentanyl use. So if a patient's not using fentanyl in the interim when they miss methadone doses, for the first 4 days, no dose change, your dose stays the same. If your dose is less than 60 milligrams and you miss 5 to 7 days, same thing, no dose change, your dose stays the same. If your dose is 60 milligrams or greater and you miss 5 days, we decrease your dose by 20%. If you miss 6 or 7 days, we decrease your dose by 50%, and 8 or more days at any dose drop down to 40. And we also increase back up fairly aggressively back to a therapeutic level for them. And then going into the second pathway that we recently created, which has been in practice for the past few months and has been working really well with daily fentanyl use. So if folks miss 1 to 4 days and are using fentanyl daily, no dose change, dose stays the same. If they miss 5 or more days and their dose is less than 60 milligrams, same thing, no dose change. But if their dose is 60 milligrams or greater and they miss 5 or more days, we decrease their dose by 5 milligrams daily for each day missed after 4 days with a lower limit of 40. So for example, if a patient is on 100 milligrams, you miss 4 days, your dose is 40. If you miss 5 days, it's 95 because you've missed 1 day after that 4-day period. 6 days, your dose is 90, and so on. And so when creating these protocols a few months ago, I was thinking about how it would be a little bit extra work for the nurses to do at the dosing window. Reasonable amount, but still just a little bit extra work for them to do. And I wanted to be mindful because our nurses at the OTP clinics are absolute rock stars, doing 10 to 20 things with every single patient above and beyond just handing them their methadone dose. So I wanted to make this transition a little bit easier for them. And so what I did is I wrote some code and threw it into Excel and created an Excel calculator, whereas all you have to do is plug in the original dose that the patient had, how many days they missed, and it would spit out the correct dose that you're supposed to give them today, and without daily fentanyl use or with daily fentanyl use. So again, if a patient is not using fentanyl daily, I'm going to have a QR code for access to this later on too if you want. And so if a patient's not using fentanyl daily, they're on 100 milligrams of methadone, they miss 4 days, the dose should stay the same. If they miss 5 days, it should drop by 20%. Miss 6 or 7, drop by 50%. 8 or more days, it drops down to 40. And as we know, after 30 days, they need a new intake. They need to be discharged. So I threw new intake down there too, just so they know. With the, and just to note as well, I've also threw a split dose tab as well. So it works for split dose as well, split dose BID. And it's worked out really well so far. And I've got a QR code access with a link to the Dropbox for this, our protocols here, as well as my missed dose calculator if anybody wants it. And so that's BHN's methadone missed dose policies. Thank you.
Well, this is getting harder and harder because everyone before me is really impressive, and I'm going to try to make something fabulous out of what we do at Brightview, which I do think is fabulous. But when other people do really fabulous stuff, it's like on a scale of 0 to 10, is this a 10? Is it a 9.5? So I'm Dr. Heidi Ginter. I'm the state medical director for Brightview. We have 3 OTPs in Massachusetts, but we have about 97 OTPs across the country. So I'm just talking here about our OTPs in Mass. We have one in Attleboro, one in Lawrence, and one in Somerville. And they're super beautiful. And so I just want to show you dignity, respect, treating patients like they deserve to be treated in a standard professional outpatient space. So what are we doing to answer this really cool question? We provide buprenorphine at the OTP. So not OBOT, OTP bup. You know what's really cool about that? Brightview's been around since 2015, and the data sets that they have been able to amass for about 20,000 patients that have been in treatment over that time in our other states have shown that there's a 20% increased retention at 90 days for those patients who are treated with buprenorphine in the OTP compared to those in an OBAT or OBOT setting. If you retain somebody 90 days, you actually start to see outcomes that we're looking for that really matter for patient care in terms of reestablishing the connections with the community that they want, reestablishing their work, their ability to function in the court involvement that they have with DCF, with other pieces of their lives. And then you also start to see their tox screens go to the direction that they wanted them to go based on their recovery goals. So that increase in 20% at 90 days is huge. The other thing that happens is patients start to have increased satisfaction with their treatment because they haven't had to fight with a retail pharmacy that treats them as if they are not a standard human because they're trying to pick up a medication that the pharmacist and others around may have feelings about. It also happens that we don't run out of medications. It also happens that we don't have a whole lot of prior authorizations. In fact, the number of prior authorizations we have to do to switch somebody from a buprenorphine naloxone product to a buprenorphine plain product is, wait for it, 0. You can just do it. Similarly, if you have a patient who is on 24 milligrams a day and you're really seeing obvious opioid debt, you know what you can do? Increase the dose. And you don't have to ask for permission. You don't have to do a prior authorization. You can just do it. So buprenorphine in the OTP really reduces a lot of the friction and barriers and the stigma that patients experience. But the coolest thing ever is what's hopefully going to come in Q4 this year, maybe Q1 next year, which is a lot of our patients who are on methadone maintenance really would like to be able to transition over to buprenorphine, either to get the sublingual versions or to get on injectable. And we can do that under one roof. So you don't have to send them to the bridge clinic where they are getting their buprenorphine and then having them come to the methadone clinic and have a lot of care coordination, communication, and then regulatory fuzziness around, are we doing this in the best way possible? If we can get this care under one roof to meet a patient's needs at the OTP where they've already established care and they feel really comfortable, mind blown, right? So I do not feel like I'm nearly as exciting as the other 2 presenters, but I do want to just sort of plant that seed that OTP bup is really kind of innovative and cool. And the one thing I'd like to just let you know is that because we are, I think, one of the only OTPs doing this locally, OTP bup doesn't come up on the PMP. Remember, this is protected by 42 CFR and a very loud beep. And so if you have buprenorphine in somebody's urine toxicology and you look at the PMP and it's not there, please remember to ask them, are you getting this from a street source or are you getting this from your OTP? Who do I need to coordinate care with? And so thank you so much. I love bup in the OTP.
Hi, I'm Sandra Gordon from Bay Cove. I'm the medical director, and I have my Bay Cove team over here. So, yes. So anyway, we are at 66 Canal Street in downtown Boston, and sometimes you think, gosh, where's Canal Street? We're right there in the north end, and It's a great clinic. I don't have any fancy photos, and I also feel a little bit intimidated following my fellow colleagues. However, we are providing, oops, that's me on the next slide. Here we go. Yes, so what I just basically want to say how we've prioritized and changed things in our OTP over the past year is that what we've implemented are multidisciplinary rounds, which you've sort of heard about, but I really am so pleased with our program because we address many of the needs I think that Caitlin spoke about, because we can look at I would just get a positive talk and like, oh my goodness, what's going on? But when I hear from the clinicians, I hear the other circumstances of what's going on, family issues, childcare issues, what the implications may be if they cannot get to their job on time. It really helps provide a much greater picture when the issues of loss of take homes come up, and it really just provides a really great avenue. So I just really want to encourage everyone to basically think about having that full input from many of your other providers. Also, our second thing that we do is that when patients have lost their take homes, we provide what we call timely reassessment so that the patients can get those back in a very reasonable amount of time. That's also, we clearly know that's also very important because of just implications, job, family situations. So yes, so I want to make sure that it ensures that we have a prompt review and care adjustment. Next slide. Yes, our other thing that we've also started to do is we've had walk-ins so that if a patient comes in, basically, and they need to kind of get started on treatment right away, as we mentioned, I think Caitlin mentioned earlier, sometimes used to be forever, 2 weeks, 1 week before they can get into treatment. We can actually see someone that day and begin to get them into treatment. We've also acquired an EKG machine, and I think many of you will know in the OTPs, we've got patients now on 190, 200 milligrams, and I personally feel very responsible. I know we've had that lecture about EKGs and the QTCs, but I do feel very responsible if I'm going to have someone go home on 15, 13 take homes that I haven't done an EKG, they're asking for a dose adjustment, that I have at least something for me to look at to see what their QTC is. So really by having that machine, we're able to do our own EKGs right there in the office. And then I can feel comfortable saying, okay, yes, let's go up on this dose. So that's one of the things that we've done in the past year. I should also mention, I didn't have it on the slide, we've also collaborated with Gavin. I think John Roberts mentioned that, yes, right over there. So someone doesn't get them, when they go into Gavin House, they don't get stuck, at 30 milligrams. They can actually come to us and we can collaborate with them and be able to write their orders and get them onto a therapeutic dose so that patients feel better in a shorter period of time. So that was one of the other things that we've done in the past year. This was also just, I think someone else had mentioned, when patients come from other clinics, they are allowed to keep the number of take homes that they have, providing that everything's been going well. We don't suddenly say, well, you're new to our clinic, you have to start off at the beginning. We accept where they've been, if they've had their 6 take homes, we can continue those take homes when they've come to our clinic. I think that was, yes, that was it. Thank you. Okay.
Good morning. Hey, so I'm from Boston Comprehensive Treatment Center, CTC. There are 12 CTC OTPs in the state, and one of them, Brockton, has a mobile unit. So I guess we're the other mobile unit. What's special about our program, along with our colleagues at the HCRC so HCRC is the Bradson Street Clinic, we're the Topeka Street Clinic. We serve the so-called the MASAM congregation, high density homeless people experiencing homelessness that are using drugs. So we have as such, we have 70 to 75% of our clients are either straight up homeless or experience severe housing insecurity. So despite all this, the psychosocial instability and transitional living arrangements, we still boast a 90-day retention rate of 75%. I just learned that the other day, so that's kind of cool. We work, one of the things I look forward to is that I get to work with the local teaching hospitals, shelters, house of correction, and I'll get to that in a little bit. So what are we doing to improve patient care and patient experience and outcomes? A couple of flashy things, and then I'll do less flashy things. Number one, a week from Monday, we are starting a satellite OTP inside Barbara McInnes' house, which is part of the Boston Healthcare for the Homeless. Yeah. So this is thank you. But honestly, everything goes to my team. Bridget, our clinic director, Bridget O'Connor, and our really young and dynamic team. So this took a lot of work on their part. I just get to be the guy that takes the credit. So, as you guys know, most of you know, Barbara McInnes is a very unique program. It's a 200-bed respite program that, I mean, if you've ever been there, it looks like a hospital. Like this is a hospital level of care, right? No, they actually operate at like a shelter. Residential level of care, and all the wraparound medical, mental health, and social services are basically like outpatient services. And so what was happening was they have on any given day, anywhere, I was told up to 30, please fact check me, up to 30 patients on methadone maintenance. And what's happening now is that they're put in vans, they're getting their IVs unhooked. And they have many of their clients are older and have severe mobility issues. They're being loaded onto vans and they're being transported all over the greater Boston area, including ours. So this eliminates that. And the other thing that I'm hoping for, and I was hoping that their medical directors would be here, is that we want to work closely with them and help in any way to start start patients on MAT, not just methadone, but all forms of MAT, MOUD and MAT for other SUD. And the other thing is, having done this before in CSS that had its own OTP downstairs, it's better patient monitoring because polypharmacy is such a huge issue at residential programs like this for high-risk patients. So you can observe them a lot closer and adjust their doses accordingly. So we're really excited about that. And then the second thing we're doing is starting Wednesday, we're going to be partnering up with Boston Public Health Commission. And right there in that same neighborhood, you guys have heard of AHOPE. It's a great harm reduction program. And so we are going to be we're going to be doing what's known as an intake day, where our team, myself, the nurse manager, lead clinician, our clinic director, are going to go there, and we're basically going to open up shop, and we're going to do intakes all day, all morning, and whoever's ready. So I mean, this is a harm reduction center, and that provides clean supplies, does testing, screening, referral, but they can do more than just referral to treatment from now on. We can actually take them with us. And this is kind of this kind of aligns with my philosophy that it's not just good enough to meet them where they are. I mean, that's important. It's an important first step for sure. But for me, as if you're a healthcare provider in the field of addiction treatment, it's not just good enough to meet them where they are. You actually have to, encourage them to get treatment. I know it's kind of a controversial statement, but you go to a baker, you get bread. I'm a physician, I'm pro treatment. So for people who are ready for it, who want it, right? So we're really excited about the intake day at Boston Public Health. A couple other non-interesting, non-flashy stuff. So I came back in February. I was there in 2022. I came back in February. I've been really, really happy to be back on Topeka Street. I've been really concentrating on improving our walk-in admission system. So I, on some Fridays, at least once a month, maybe more frequently, I do go out to Mass and Cass and hand out Narcan and introduce myself and tell them a little bit about our program. And what I do is I stress to them that if you're ready for treatment, we have a walk-in system. Come in. I'm there at 5 o'clock in the morning. Our doors open at 5. Our dosing windows open at 5:45. Just be there, and we will take you. And it's amazing the kind of questions I get asked. And the number one is, do I need an ID? And I tell them that our definition of ID is rather stretched. We get all kinds of excuses for ID. Will I be dosed on the first day? How high will the first dose be? A 30 milligram does nothing for me. That's why I hate methadone. All those things we take to heart. And one of the things I've done as medical director is to really shorten that walk-in process so that everyone's dosed by 2 hours, usually within an hour. So, and I know it's kind of boring, but for us, that takes a lot of coordination between clinicians who have to run groups and medical providers who are busy doing annual physicals. So it takes a lot of cooperation. Sorry. Okay. And so we're really trying to shore that up. Anything else? So do I have a minute?
Yes.
Okay, good. All right. So so on the personal side, again, there are two special at-risk populations that I told Bridget, our clinic director, when I came back, that I really want us to focus on. And number one, it's our pregnant clients. We are very lucky. We work with our wonderful folks at Project Respect at BMC, the Hope Clinic at MGH, really great people. And I love the warm handoff. And I'm putting a lot of emphasis with our providers to, it's not just good enough to see the prenatal visits every 2 weeks, but really focus on postpartum, what to do with their doses after, because their doses get increased, and we really need to have a closer monitoring to make sure that they're not on a dose that's too high, because that causes other problems down the road. So we're and then the other one is the incarcerated population. The Suffolk County House of Corrections is literally across the street. This is kind of a full circle moment for me, because back in 2018, I was involved in a case, Pesci versus Essex County House of Corrections, where we sued on behalf of one of my methadone patients, and we won. And that was a landmark case. So so that became like this, national. So that's probably the population that I'm most interested in, because they are so much at risk, and I really don't like this mass incarceration thing. So yeah. So anyway, so that's my thing. Thank you very much.
Good morning. I don't have half the energy of Shorta, so forgive me. I'll try to be as enthusiastic about our program. So I really am enthusiastic about our changes, and I'll try to convey that. I'm Dr. Crosscup. I'm Katie Crosscup. I'm the medical director of Mira Vista OTP in Holyoke, keeping it real in the 413, fighting the good fight with Ruth and Ari and others. So I think you probably caught on that we all are basically presenting along the lines of similar themes of improvements in our OTPs. And so for us, we're really seeing individualizing treatment and improving access become priorities for the care that we give our patients. And we've been able to do so based on all the things that people have already expressed today: the pandemic experience, the changing regs, BSAS, tremendous support and advice. We've had a SOAR grant that's enabled us to provide care through recovery support navigators and other outreach efforts in the community. And also just a thanks to our patients who've been incredibly vocal and supportive and patient and flexible. And we have an incredibly creative team. I just want to acknowledge Heather Roos, who's the PA that we work with here. She's my co-collaborator, keeps things patient-centered and realistic as we make these changes. So along the lines of patient-centered changes, we've also implemented, like many others, faster buildups based on the newer guidelines and the newer evidence. I suggest that you can start people at a higher dose if necessary and increase at faster rates, but we've also customized our buildup. So we may enter a buildup on someone's admission into our EMR, but we tell the patient, on day 2, if you're not feeling well, just tell the nurses and they'll call us from the window, or we'll come down. We'll discuss with the nurse and the patient what seems appropriate for their next dose, and we'll go from there. We've also created a system of less rigid and more forgiving reinstatements that looks at whether a patient has been using in their interval of AWOL or not. And so we've tried to do something along those lines as well. We've allowed for more AWOLs from clinics. So we realize that people are trying to live their lives and sometimes they miss a dose. And so we're much more forgiving along those lines as well. And accommodated schedule changes too. We've also increased our in-OTP services. So we've been collaborating with the state to provide nicotine replacement, which many of our OTPs are also doing across the state. We have fentanyl test strips, we have harm reduction kits, and we have some food resources also that we've begun to provide. This slide demonstrates bottle allotment for our OTP from 2018 compared to what we're doing currently. And so you can see that given our new approach, which is along the lines of what Ari described earlier, where we really talk through the patients at every MDT for whether they're eligible for bottles. If they don't have them, why don't they have them? If they do have them, can they have more? We sort of discuss what's new in their lives, how we look at the domains of recovery. Is that a warning sign? How they're, how the bottles are improving their lives, if they have any red flags, how much of a red flag is it really? And so you can see that in 2018, most of our patients didn't have any bottles. And then currently, most of our patients have 6 or more bottles, with about 30% having 27 take homes. And almost everyone has a Sunday. Obviously, we are open, but for fewer hours than usual. And we have an opt-out for Sunday. So if Heather or I on admission or the nurse expresses concern, then the patient will not have a Sunday, but otherwise they get a Sunday bottle. And this is a pretty fluid graph. So we really do spend a lot of time and attention in determining whether we're actually helping somebody's recovery and can we be helping them more and move them into the next category of allotment. And then quickly, just in terms of access, we have same day admissions every weekday for walk-ins. You can schedule an admission if you like, and you can usually get a schedule the next day or quickly thereafter, or just come right in. And we do direct admissions 7 days a week. So if a patient comes to us from another facility with a last dose letter, we'll accept them into the program, continue their dosing, and get them for a full admission as soon as possible. We also have some internal referral processes that we've improved, including consult service for our inpatient psych admissions. A variety of other administrative processes have improved, and we've been working on transportation and improving access to PT1. This is stuff for the future. I'll skip. Thank you very much.
Morning. A little loud. Nice to see familiar faces, and thank you, Heidi, Ruth, for asking us to give a little presentation. So I'm Alfredo Gonzalez. I'm the Chief of Medical Service at High Point Treatment Center. We run 3 OTPs. Our oldest is the Brockton, and our oldest and largest is in Brockton, and the newest is Plymouth, and then New Bedford is in between. I am the medical director for Plymouth and New Bedford, and Dr. Maniktala is the medical director in Brockton. He taught me everything I know about methadone, so I really appreciate that, along with the support that we received from MASAM and SAMHSA. Along with these OTPs, we run over 100 ATS beds in the 3 locations and CSS beds. So I feel like ATS has a lot of involvement on a daily basis with methadone. So, and in order to do all that work, I work along 15 other practitioners. So without their support, we couldn't do any of this. I did query the group for answers to these questions. And so I'll start in Brockton. Brockton has a unique campus. We have OTP, ATS, CSS. And the 2 newest units are sort of pilot projects for behavioral health and crisis or psychiatric instability. And so on those 2 very small units, one of them is a 72-hour psychiatric holding, and the other one is a step down. But on those 2 units, along with the CSS, we've embedded Hiroko, our nurse practitioner, who is also working at the methadone clinic. And so she's able to actively see those patients whenever they need to be seen, and sort of avoid some of the trying to go back and forth, trying to make sure that the home clinic is going to be okay and sort of things like that. But I think that has been really very identified as one of the practice improvements, especially in Brockton. I've listed a couple of the support staff and program leadership across the 3 clinics, but I'm failing to list the many very special nurses and clinicians along these sites. In order to comply with the final rule, what we decided to do in terms of a monthly assessment of take-home is just to do a quarterly census every week. So we take our census and go through the alphabet for take-homes and issues. I mentioned the practitioner's dual role from the OTP and those units. So that's been really good for communication and integration of care. In New Bedford, mention was made that the dosing room has been improved for privacy and increased handicapped access. And then I was sort of struck by ASAM's 2020 updated guidance that said that all patients with opioid use disorder deserve whatever form of MAT they want at any time. And I felt like that was very difficult to accomplish in a methadone population. So that, along with the Bernese method, I feel like patient selection in using microdosing with buprenorphine in that setting has been transformative for many patients. So I think that patient selection, as far as that goes, is really important because that really will determine their success, I think. I think just to echo what BHN was speaking with earlier in terms of sort of this clinical stability and medical directors' decision-making and shared decision-making has really, we take that to heart, and it's really difficult conversation, and I applaud BHN for coming up with policy and that workflow because I think that that's very valid. We've been doing that, but not in such a formal way. I think the other big piece that we've been talking about is really this dosing guidance was also mentioned. I think some of the guidance that we were sort of were following seemed outdated and not relevant. So we will probably take some points from BHN's presentation as well. I think that's it.